I'm Hannah Azzaim, professor of psychiatry at Ain Shams University. And this session was supposed to take a form of a debate. I hope Dr. Ola is going to join soon. So I tried calling her, not sure whether she's the one calling her or not.
دكتور أنا كنت أنا هواصل.
So we have, during this hour, I thought of making this more of an interactive session. What do you think about the prevalence and the cost of autism spectrum disorders? What do you know about the prevalence?
I think now 1 to 68, one from every 68 child has autistic spectrum disorder.
Yes, this is about 15 years ago. We used to study that it was 1 per 100,000 cases, and these are the most recent studies saying that prevalence ranges from definitely it's among boys, among males, but the estimate of both genders is 1 every 68 child is suffering from autism. And there was such a question that still needs to be answered. What is the cause, what's the reason for that sharp rise in the prevalence? Is it to do with the diagnostic criteria, the change in the diagnostic criteria? Is it to do with have new reasons like environmental pollutants or something of that sort? Is it to do with increased awareness? Is it to do with pharmacologically supported, what do we call it, propaganda? So raising the awareness for any...
ماشي دكتور هي علا تشات بيرسون بتطلع لي تحت ف I think إن هي هتطلع لنا كمان شوية.
So this was a question that needs to be answered. Why do you think this sharp rise in the prevalence of autism? Is it to do with which of the causes that I just mentioned do you think explain this marked rise? Yes. Any suggestions? Yes, and let us just give a small hint about the rising cost as well. So it's very alarming. And if we consider that here in Egypt, most of these costs are out-of-pocket expenses of the families, so we can imagine how much of a burden treating a child with autism is. So this study aimed at answering this question, aimed at answering whether this sharp rise in the prevalence is caused by a change in the diagnostic criteria or other factors. And to me, it was quite interesting that the rise was 600-fold previous estimates in 1990. Some of the reasons behind this rise is the change in the diagnostic criteria, yet this does not explain it all. 400% increase after correcting all other factors. So the prevalence actually rises even after correcting changes caused by identifying more milder cases and the change in the diagnostic criteria. So if we have a quick look on the DSM-5 and changes that has occurred in the DSM-5 concerning the autism spectrum, one of the most apparent changes that has been done is the removing or the exclusion of the language criteria. It's no more a must to have a language disorder to diagnose or to fulfill the diagnosis of autism spectrum. And what's quite interesting is the inclusion of the sensory responses or abnormal sensory responses in the core symptoms of autism spectrum. this is what we were just talking about. On the left-hand side were the DSM-4 revised criteria, and this last one, the restricted repetitive behavior cluster, is retained in the diagnostic criteria for the DSM-5. Yet the language, as we said, the language and the social communication has been fused into one single criteria. So instead of needing to have three major diagnostic criteria to diagnose autism, it has been just two main diagnostic criteria. One of them is the persistent deficits in social communication and social interaction, language being part of this or not. The restricted repetitive behavior cluster is the second diagnostic criteria. When they first thought of writing the DSM-5, their main aim was different than what has happened later on. Their main aim was to try to add some etiological factors to DSM and to classify according to some biological markers or some biomarkers that might have had its implications on the therapy. But unfortunately, this wasn't too much possible. They tried using the Genome Project and the Connectome Project to add some knowledge to the autism spectrum, but unfortunately this didn't add a lot. Yet they tried overriding this by adding dimensional view to the DSM-5, adding and focusing on the dimensionality and the specifiers for autism spectrum. So they omitted Asperger's, they omitted the autism not otherwise specified, and they needed a diagnosis or a specification whether there is an intellectual impairment or not, whether there's language impairment or not, or whether there are associated behavioral problems or not. Thus, they allowed for the diagnosis of comorbidity, especially of ADHD, which was previously DSM-4 prohibited to diagnose both the disorders. Okay, so what do you think happened to the diagnosis of autism spectrum if these factors were added? What do you think would happen to it? Yeah.
انا كنت هعلق بس على هو احنا سبيسيفاي لو في لانجوج ومفروض مش حالات الاوتيزم كلها بيبقى فيها language.
Not according to the DSM, according to
communication rather than
communication.
communication. هو الاوتيزم زي disorder في الكوميونيكيشن، فلازم حته اللانجوج دي بتبقى فيها ايه؟
As we just mentioned, أستاذ الدكتور هنا إنه the criterion for language has been removed, خلاص, and it's been replaced by a wider problem in communication. So whether this problem is in verbal communication or not in verbal communication doesn't matter. So لو احنا قلنا كده، لو احنا استبعدنا ان اللغة شرط اساسي للتشخيص، فلما هنعمل كده when we add all these specifiers, what do we think would happen to the autism spectrum? Yes? It would get more diverse, or there would be more focus about the heterogeneity and the diversity of different types of autism spectrum, and it will possibly include milder cases that hasn't been diagnosed before, because before we needed 3 diagnostic criteria. Another point in the DSM-5 was adding the severity criteria, and we assess for severity according to how much support does the kid of autism need in his life, and the major aim of therapy is to promote the level of functioning of the autistic kid from one level to the better level. Yet, here arises a question, which is, what if this functional impairment is not caused by the core autistic symptoms themselves? Like, if, for example, the main problem of severity and for me having a functional impairment was my intellectual disability, or my ADHD problem, or my motor or my epilepsy problems. Okay? So this is one of the points, of the weak points that still needs to be clarified, because it does not state here with all these comorbidities approved to be associating the autism spectrum, how can we rate severity? Laura, would you like to join?
Then we talked about the specifiers. The other thing which is very important that is related to heterogeneity concerning, you have mentioned already the criteria of this autistic spectrum disorder with all the specifiers. One of the intended, sorry, I would like just to have, is that concerning the heterogeneity is that autistic spectrum disorder, the symptoms of it changes over the lifespan. This is one issue. The other thing is that it is as well changing the symptoms in a periodical way. For instance, some symptoms are existing at some time, and then after on intervention they disappear. Later on, the mother might complain of the same symptom that arises but somewhat later, after improvement of the child. So we find that the picture of this autism is always changing. Concerning the three main criteria, the interest, activities, the communication skills, and all the other associated disabilities. We have another important thing is that being a neurodevelopmental disorder is usually associated with other comorbid disorders. As Dr. Hanan has mentioned, she mentioned the intellectual disability as one of the comorbid, which we call sometimes high functioning or low functioning. It specifies the patient as this, or the child. In this case, we can have other neurodevelopmental disorders that can be reflected as in the form, of this is the slide. There are other comorbid psychiatry disorder that is very common. We found, for example, that depression and anxiety, especially at the time of adolescence, might amount up to 60% of autistic children. So it can be a comorbid disorder that is already existing. Other things like tic disorder is very common. Anxiety disorder is very common as well. This in addition to other other challenging behavioral symptoms like the hyperactivity, either as a symptom or as a syndrome in the context of attention deficit hyperactive disorder, comorbid disorder. Another issue, the irritability that appears in the form of tantrums, mood dysregulation, aggression, self-injurious behavior. All these behaviors are considered challenging behavior that are either represented as a symptom or as a syndrome comorbidly existing with the autistic spectrum disorder. And then was supposed that another issue related to autistic spectrum disorder concerning the heterogeneity of etiology. We find that autistic spectrum is a complex biological disorder. It has some genetic basis. On the other hand, the environmental factors can make like a form of changes or gene mutation that can be expressed in a different phenotypic presentation. So it gives us different modalities of the spectrum itself. On the other hand, we can find that almost about, it runs in families. This means that about 60% of the twin studies, we can find other autistic features in the SIB, especially in the identical twin. Also there is a risk for those other siblings amounting up to 8% of the kids. In addition to this, we have also other genetic disorders that can be associated, like the Fragile X syndrome, that are related to a specific gene, or the tuberous sclerosis. So it's a clear monogenetic disorder, but it has other autistic features. So these are considered some of the heterogeneous factors that is related to genetics that might be essential and as well responsible for the heterogeneity of the spectrum.
So another useful addition to the DSM-5 was the invention or the adding of the social communication factor disorder, which is all kids that does not have any stereotyping, yet they have this first diagnostic criteria referring to having problems in communication, whether it's verbal communication or non-verbal communication. Sometimes kids do speak, but their language is not properly used for the purpose of proper communication. Okay? So it's more of the semantic, pragmatic deficit sort of thing. Because language at the core of things is needed for improving social relations and improving social understanding. So if a kid has only problems in communication that's negatively impairing communicating with others, and he's not fulfilling the other criteria of stereotyping, now he can fit perfectly in this category. So these are the changes. And as Dr. Ola has just said about the heterogeneity, so I guess this slide is a mix of the heterogeneity regarding the clinical profile, associated medical conditions, associated psychiatric disorders, developmental disorders, and the neuroimaging and PET study functions. So I guess this says it all about the heterogeneity. This is not all. Even if we take just one circle of the previous etiological factors, which is the GIT-associated symptoms, even among one of these circles we have very diverse and very heterogeneous problems in the GIT in its own self that can be present in the autism spectrum and explaining its etiological, it might be an etiological effect. It's important to put in mind that the prevalence of medical problems are significantly higher among autistics as adults or autistic children as adults. So there's significantly higher rates of cardiovascular diabetes, obesity, GIT problems, early death. And to this, I strongly recommend being more aware of prescribing antipsychotics for long durations of time without being medically supervised properly. Because a kid, if started on risperidone since the age of 3 and continuing till who knows when, what would I expect? Another thing is that, as Dr. Ola has just mentioned, during the adolescence in particular, we find that there are lots of changes happening in the autistic kid. So it might be just the accentuation of the autistic symptoms, yet we have to exclude new onset psychiatric problems because it's significantly higher than typically developing children, especially the OCD, especially the psychosis, especially the catatonia. Catatonia is quite prevalent among autistic children, so especially during adulthood and adolescence. So, talking about all this diversity, are we talking about one autism or autisms? According to Waterhouse, he thinks that the concept of autism as a single entity lacks validity at a biological level. Being one autism, to him, it lacks biological validity. Because of this multi-level heterogeneity, it's not only on the level of symptoms, but on the comorbidity, on the etiological factors, on many, on the pathophysiology level. Okay? So there is a genetic element in autism spectrum, evident by the higher comorbidity, or the higher concordance rate among monozygotic twins, the higher concordance rate among siblings compared to the general population, yet genes does not explain the whole.
After you finish the genetics?
This is just to say that even if I say one etiological factor, the genetic factors, you can see how diverse the genetic factors are. So,
the other thing, the genetic factors doesn't mean that this is the only responsible factor on the clinical presentation of the autistic child. On the other way around, the genetic risk factors or genetic variants can make like a form of pathophysiological changes that serves to form like a form of that affects the neurotransmitters as well and the neural circuits in the autistic children, especially the developing brain of the autistic children, and this represent targets for even pharmaceutical intervention because it gives like a background for to explain some of the disorders that or the problems that is existing in the autistic children. For example, this for the NAMDA DM, the DN-methyl aspartate, the glutamate اللي هو GABA genetic preponderance, the scaffolding checks 1 and 2 and 3, all these are affected very much by some genetic variants that leads to or invites for treatment by medical intervention because it improves the picture. The other thing, there are some theorems that explain some of the autistic features like the serotonin, excitatory glutamate, GABA inhibitory factors, as well as the immunological system involved, the dopamine and its role in the development. And this has been explained by two main factors. The similarity that exists between autism and schizophrenia, that is a long-standing issue, and it passes into many debates whether they are the same disorder or they are two different disorders. And the response to medication at some time can respond or can give a form of clarification for this because they might share the same substrate or the same neurochemical abnormality that is existing. And this can explain some of the neurobiological effects of problems that are existing in the autistic spectrum disorder. Also, there is the oxytocin, and we know the role of oxytocin and how it affects the regulation of the glutamate, the excitatory glutamate, GABA inhibitory relationship, and how it modulates the attachment and invites for social cognition, better social cognition and interaction. And this represents one of the chemical substrates that is very important or plays a role in the development of the autistic behavioral and symptomatic disorder.
Okay. So what's even more complicating matters is that not necessarily inheriting a certain gene would imply having an autistic disorder. Sometimes I would have this gene, but due to having protective environmental factors, this factor might be locked off, so it's not functioning. So this is what's meant by the epigenetic factors. So the epigenetic factors are environmental factors that might change gene activity, the gene expression, whether it's a protective gene or a pathognomonic gene or a pathological gene. So it's quite interesting and important to study the interaction between these three wheels. It's not only the genetic factors and the environmental interaction, but but as well the timing. When was the kid exposed to this particular environmental factor? At which critical period of development? Whether it was intrauterine, whether it was during his infancy. That's another interesting area for scientific study, and it might have protective interventions, key intervention for primary protection. This is one of the studies trying to explain how environmental factors might affect the gene mutations. Okay, so it might change the gene in different ways. Apart from the too many scientific jargon, okay, at the end of the day, we need to treat autism. So autism needs a multimodal approach, and this multimodal approach should include pharmacological as last resort, yet behavioral and educational should be the main way to treat autism spectrum. It's important to go for an early assessment and to identify certain treatment targets to know exactly what I'm aiming at to be able to follow this. So, to plan for treatment, I have to do proper assessment. Proper assessment entitles not only diagnosing that the kid has autism spectrum. There are many factors. The cognitive functions of this kid, social relations, parental mental health, associated comorbidity, physical problems. So actually, the level of family functioning, the level of family stress. So there are lots of points to be put into consideration during the assessment of a kid with autism. It's not the end of the job to say that this kid is just suffering from autism spectrum because of this heterogeneity, things differ. So it's a continuous process of identifying the goals, selecting what intervention should take place, and determining progress and monitoring the procedures, monitoring the progress to see what is limiting the improvement if there is some. When we go for small research, we, generally speaking, we might have a finding, and the opposite finding is the just very close space. So it's very annoying, it's very confusing whether this is an effective line of treatment or not. So what solves this confusion to a certain extent would be the guidelines or going for systemic reviews, which collects many studies, well-designed studies, and compare between different studies concerning different points or different approaches. So these are some of the famous systemic reviews, and as we see, it does not assess the whole interventions for autism spectrum. It just takes one behavior intervention by one and assess to what extent was it useful and in which domain, in the behavior domain or in the cognitive domain. So this would comfort us in a way in trying to find which might benefit, generally speaking. But the other problem would be these meta-analytic studies or these systemic analysis might be right and very useful, yet they do not speak for this particular boy. Okay? So it's important to be guided by the guidelines, it's important to be guided by the systemic reviews, but bear in mind that we are tailoring things. We are tailoring treatment. Yes, please.
In addition to what have been presented by Dr. Hanan concerning the evaluation, I would like very much to press on two things. So long we are talking about neurodevelopmental disorder. During the physical examination, we should not forget to make an EEG for the child because the comorbidity of epilepsy is existing. It's mandatory as well to assess for gastrointestinal problem because we have some of the autoimmune diseases like the celiac disease is very common, and some of the patients are presenting with autistic features, and the main problem is related to some problems in the absorption, which is called malabsorption syndrome, and this I think will be mentioned in management plan of autistic children. The other thing, we have to put a hand on the sleep disturbances that might be associated with autism, because this point is related to other factors rather than the main mental disorder. It might be due to a toothache or tooth problem. So we have to consider this, because many times we think about the irritative behavior of the child as if it is due to the syndrome. Sometimes it is due to another far away that it never comes to our mind, like this, just a toothache or a discomfort in the stomach, and these two variables can affect and increase the symptoms of the child. So we have to put a hand on this. And the other thing, we have to notify when the symptoms have been aggravated or diminished, and what are the factors that affects this change. Is it a change in the environment itself, or a change in the physical context, or the child hasn't been sleeping well, the sleep hygiene of this child, because all this will be reflected on the challenging behavioral problems that we meet a lot in the stage.
This reminds me of an autistic child that has been sexually abused, and there was marked deterioration in his symptoms over the past 2 months or so, and the mom has just recognized that this abuse has happened by the boy trying to show her or to do reenactment of the sexual behavior. So this is as well an important point. When we find a deterioration of the case that cannot be explained, we have first to exclude medical problems, second to exclude psychosocial factors or trauma, because these are quite important.
It's quite important, and the kid cannot express himself and cannot conduct this problem because they have many times problems in their language expression especially. So it will be.
I've been talking to a friend a couple of days ago, and he was just curious, how come that you're saying that autism is an organic disorder, that there are some brain pathology behind autism spectrum, yet the science all that years haven't reached what's wrong. I kept thinking, well, what's keeping the science from reaching this solution, or reaching an answer for this solution? Well, the heterogeneity plays a role as well, because as we will see, most of the scientific studies that have been performed so far has not, except for the last maybe 7 or 8 years, have not put this heterogeneity into consideration during planning the research work. So this is one of the ways that the National Institute of Mental Health is trying to go through the maze of psychiatric disorders in general. It's called the research domain criteria. In the research domain criteria, it's trying to, the National Institute of Mental Health is trying to think in a different way, in all the psychiatric disorders, thinking of them as lying all of them on the spectrum, different spectrums. So there's a spectrum for social cognition, there's a spectrum for arousability, there's a spectrum for executive functions, and to have it one or another disorder, call it schizophrenia, call it bipolarity, call it autism spectrum, you should lie somewhere in these different domains. And they are trying to find for each and every one of these different diagnostic domains its phenotypes. علشان انا هقولها بالعربي عشان الكلام يبقى واضح. يعني مثلا بيشوفوا حاجه عرض مش مرض، بيشوفوا عرض زي الوركينج ميموري، بيشوفوا الوركينج ميموري قصور الذاكره العامله او الوركينج ميموري ايا كان في كل الديسوردرز. خلاص؟ وبعدين يشوفوا الشخص اللي عنده قصور في الذاكره العامله ده هل في عامل مشترك ماشي ترانس دايجنوستيك في كل الديسوردرز متشابه جينيتيكالي، برين ايمجينج، الكتروفيسيولوجيكالي، ولا ايه الاخبار؟ ف it's quite promising thinking of that way لانه في الاخر the diagnostic criteria are man-made. So who said it's just a constellation of symptoms? Maybe this is one of the things deferring us reaching a step further.
I think this is what's happening in the DSM-5, and they are returning back for generalization and dimensional rather than before in the DSM-4 and the
Because
before we move to the other, I would like to admit a very important, when we have to search for autism in children, there are some risk factors that are existing that should make like a form of a percussion or a red flag that we have to look for all the symptoms and the spectrum of autism that has been mentioned. What's most important is if we have a family with an autistic child, then we have to make this full screening for autism that have been mentioned. If we have some autistic behavior in the child, like the communication problems or the stereotypic behavior or lack of interest, those who are born to an old parents, many times, and this is the trend nowadays, that the girls and boys prefer to marry in old age. I mean old age above 35. So in this case, and they are waiting for a baby, we have to consider autism because this might be one of the risk factors that is existing. The other thing is the existence of some genetic conditions in this family, like Fragile X syndrome, if it is existing in one of the family members. Also the children at risk, which is very common as well, which is the premature kids or the very low birth children. They are children at risk because we know and we have read about the environmental genetic inequalities. And in a lecture that I was attending downstairs, the professors mentioned that the existence of environmental factor in a or in a genetically predisposed child increase the risk 70 times to develop the disorder. So if we have a family that has a risk of having a child of low birth weight, and at the same time they have another child with autism, the risk will be increased 70 times. So I mean, all these factors we have to consider in order, number one, to start intervention that will be soon, very early, and to early detect the cases.
So when we go for research, for updates in research, we find new modalities talking about anti-inflammatories being used and COX inhibitors and things of that sort. We find things about the antioxidants for targeting mitochondrial dysfunction. We find things about the oxytocin and the valvaptan, the vasopressin agonist. There are lots and lots of modalities. Let us have a hope that if we, instead of going like a blind man, just trying and using trial and error in our kids to reach which medication fits this child, if we do have a biomarker through which we can know this would be a great step in the direction of the personalized medicine. So if we are to talk again about what's hindering research, so one of the things hindering research was the way the data was collected and the way kids were stratified. لو احنا هنشوف الستادي دي خلاص البوبيوليشن، لو انا خدت البوبيوليشن كلهم ان دولت مجموعه من الاوتستيك تشيلدرن وكلهم I added an apple to a banana خلاص وكلهم سميتهم اوتستكس، هيطلع وعملت نفس الانترفنشن ممكن جدا ما يطلعش فيه فرق او يطلع فيه فرق خلاص في are divided according to the specifiers, whether they are biological specifiers, سواء كان MRI, genetics, GIT manifestations, things might vary a lot. This is a point to keep in mind, especially on doing our research projects. According to what are we classifying, or are we putting our cases, and are we putting our content? And that's why the current trend is in the direction of the big data. The big data, many institutes come together and they share their information to be able to subgroup kids with autism at different levels of subgrouping, bearing in mind the genetic, bearing in mind the other biological factors, as well as the clinical picture and the response to treatment, trying to subtype or to reach a more comprehensive way to know which kid would benefit from what. And among these studies is the LEAP study. It's a longitudinal European autism project.
I think one of the most important things here that might be somewhat different is that all the studies that have been conducted on autism, they are lacking, especially for psychopharmacological intervention or even the biological background. They rely upon a very small number of cases. With the small group of cases, we cannot generalize the findings. The other issue, they are mostly lacking controlled studies. So this will be one of the limitations, that we shouldn't rely upon, or we cannot generalize the findings that is existing. So at evidence-based medicine, they cannot find this form of systematic review studies that rely upon well-established, controlled, big number of cases that can give us a reliable result. So we find inconsistency in the findings. Some result might give me, for example, that there is an increase in the serotonin in the frontal cortex. Other studies will find the reverse. Or other studies will find, for example, a form of cortical impairment or insufficiency or instability in the glutamate, GABAergic excitatory inhibitor. So in this case, we'll find, for example, 12 studies. No, only 3 studies that agree upon the finding. And the rest of the 7 have either equal results or they null this hypothesis. So this is one of the most important things that we need to form on the long term, like a big study. When the next study is not relying upon the pharmaceutical companies, because it should rely upon the network of autistic children, so that we can gather real patients with sincere people who are caring for, like the charities, for example, under the control of a governmental support, so that it will be like a form of a main project to review all these findings that we either on a biological level or medical, therapeutic.
And the way of processing these big data is through computational psychiatry. This computational psychiatry it's aiming at better processing of this huge amount of data. So it's a huge number of patients, and each and every patient has too many variables. And thus, this needs to be to find the error, to be able to cluster cases together. And after clustering these cases, they find which treatment suits who. So this is the computational segment. At the end of the day, what we need is a behavioral program, education and learning program, medications, and we should consider other treatments and therapeutics. It's important to pass through this hierarchy of all the time, including different services, as we said, managing sleep problems, managing the core features, and and in addition to managing medical and physical comorbidities. This is when you refer to the NICE guidelines. What has attracted my attention was this slide, which talks about what not to do rather than what to do. And to me, this was quite interesting. So they said very blankly and very clearly, no for hyperbaric oxygen. They said no for chelation therapy and for CPT. Okay, because when we see lots and lots of parents suffering and paying all their money in such therapeutic modalities, and as well as auditory integration. According to the NICE guidelines, it does not view auditory integration as a useful therapeutic modality.
Yes, the other way around, we never ask about this complementary alternative therapy because many times we think that the patient is coming to the psychiatrist for intervention, and we are occupied by our different intervention programs and educational programs for the parents themselves, as well as intervention using some therapeutic, some psychopharmacological agents according to the different neurochemical or background of the autistic. And in this case, we forget about this. So many times we find that the patient, the parents themselves, they are using like a form of a complementary or alternative therapeutic intervention, like what Dr. Hanan mentioned. This is one issue. In addition to other like the yoga, the music therapy, the art therapy, they never admit this. Many times they go through the food, gluten and casein cessation or special diet, and they never admit this. So this is very important because this, it's in a way, there are some studies, and still I'm saying it is a small studies, but they give a hint that there is improvement in some of the social communication and the emotional interaction that is related mainly to glutamate, to casein and gluten restriction. This is one of the evidence-based studies that have been done. Another issue is the use of vitamins, because many times you find in the prescription that the physicians are writing mega vitamins, like the omega-3 and vitamin B6 and so on. They found that yes, it might not be harmful if used in a moderate amount, but if sometimes they give heroic doses, they might pass into a form of toxicity. They can be exposed to toxicity. One of the main things that we are now acquainted with is the chelation therapy, which rely upon that the hypothesis that autism is due to copper, zinc, and magnesium intoxication. And we find some physicians go to use like and mercury as well, and they make like a form of a chelating intervention, and this exposes the child to many hazardous conditions. Yes. And many medical problems. These are the items that we have to admit. So we have to think about this complementary drug regimen or complementary diet regimen that the child might passing without admitting this to the psychiatrist. Because we have to consider the hazards of using this, and to be aware that nothing of this are have a documentary evidence-based use.
So speaking about documented use or the approved indications of medications, we currently have two FDA-approved medications for autism spectrum for some of the associated symptoms with autism spectrum, which are the risperidone and the aripiprazole. And lately, the vasopressin antagonist has been added as an FDA-approved medication, the valvaptan, and it's claimed to improve social relatedness and social communication. So, regardless which medication we're using, if we have comorbid conditions or whatever, our medication should target these symptoms in case these symptoms are causing functional impairment. Yet, the core autistic features has to be managed using behavioral interventions. So we might add pharmacological treatments, the FDA-approved pharmacological treatments I've just mentioned, with one symptom or more than one symptom on mind, just to trace this symptom whether it has improved or not. And according to the NICE guidelines, we should keep the child on the medication for 8 weeks, on the antipsychotic for 8 weeks, and reassess for the possibility of withdrawing it. So it's not that long-term use that we see in our pets. And this is about the Valvartan that I just mentioned. Some of the more evidence-based behavioral interventions was the ABA, Applied Behavior Analysis Study. It's been there for quite a while currently. And among the useful social skill training is a program called Lunch Bunch and Other program for social skills. And as we said, there are common additional behavioral treatments, and this is our future hope, to reach a personalized intervention for each kid with autism spectrum. And thank you very much.
يعني الجلوتين ريستريكتد دايت has no value unless the patient has celiac disease. الجلوتين ريستريكتد دايت has no value unless the patient has celiac disease.
لا. It improves sometimes الattention and motor activity. But the issue is that إنها ما هياش يعني مش معمولة على بالظبط. لا it's like a case reference. دي لأنها معمولة على مجموعات صغيرة من الحالات. فبيبقى كلها small samples ما نقدرش نعمل لها generalization. Some cases are improved yes. واحنا حتى بنلاحظها في البراكتس بتاعنا. لكن ما اقدرش اقول ان ده يعني
في بعض الحاجات فكرة ان انت تمشي kid on a diet, on a restricted diet is quite hard. It's not that easy. So there are, to my mind, there has to be some evidence that this kid might benefit. Some of these evidence is having GERD, gastroesophageal reflux as a child. Some of these evidence is severe constipation as a child, diaper rash, severe diaper rash while he was a kid. So these are some of the clinical pictures or the clinical manifestations that might increase the possibility of him having a comic allergy or something of that sort. Another thing would be the lab studies. Yet, lab studies are positive, but poor negative. They are good positive, yes, but poor negative. يعني أنا ممكن يبقى عندي food intolerance وما يطلعش في التحاليل. So they are good positives, but they are bad negatives. لو في حاجات من دي and the parents are willing إن هم to try, why not؟ معرفش رأي حد إيه. why not if they're willing, and some kids do benefit. وهو ده اللي احنا بنتكلم عليه، إنه احنا ليه مش عارفين مين اللي هيستفيد. هو ده اللي احنا بنحاول نعمله. هو ده اللي بنحاول نعمله، إنه مين اللي هيستفيد. We liaise with the GIT, and I do liaise with the GIT professional.
احنا ليه بنعمل ده؟ علشان الشعر ده isn't reasonable ولا ان هو يجي ويحتاج امتى لو كان exposed to some of the environmental factors اللي هي ممكن تدخل fits. very simple لو واحد هياخد حاجه سكر عالي او ياخد حاجه حادقه زياده عن اللزوم لان احنا عارفين ان عندهم a form of resistance وفود preference اللي هو picky في بعض الاكل وبياخد حاجات ممكن انها expose او we have to consider this as a form of حتى احنا ساعات الدراج ريجيم بتاعت في حاجات بتدرسك دي fits زي but we have to consider this في management that in case لو احنا we are going to use medication for the treatment as we have mentioned. يعني فاهم قصدي؟ ساعات انت بتعمليها عشان مود ستابيلايزيشن او تعملي الاجريسيف
في سؤال تاني يا استاذ عمرو، هل في لينك بين الاوتيزم والسكيزوفرينيا؟
في لينك بين في الستاتس كلها الكيميكال ستاتس في تشابه وكان زمان بيسموا الاوتيزم فورم اوف تشايلد هود سكيزوفرينيا ده بالهيستوري، وبقى بالبيولوجيكال ستاتس وكده لقوا ان هم شبه بعض في حاجات كتيره قوي في الستراكشر اوف ذا برين وكمان في الريسبونس للميديكيشن.
بس هو البرونينج بيقل في الاوتيزم وبيزيد في السكيزوفرينيا، اللي هو تشغيل النيورونز يعني. الساينابسس بتكون النيورونز بتبقى بتقل.
هي معتمده على الدوبامينرجيك ده مين هو اللي بيفسر الاثنين والريسبونس للميديكيشن الحاجات اللي بتشتغل.
في ثيوري في السكيزوفرينيا ان هي نفسها neurodevelopmental. Schizophrenia is a neurodevelopmental disorder, meaning that there is a problem في synaptogenesis and pruning, a problem. خلاص whatever this problem is. هو في there are some of the autistic kids that have defective pruning, whether it's too much pruning or under pruning. High synaptogenesis without enough pruning. And this explains a sector of autistic kids who have sometimes they have large brain sizes. Large brain
عندي سؤال، الاوتيزم انتجريشن ثيرابي حاولت تقولي ان هو
لا هو احنا بنقول دي واحده these are alternatives. These are alternative complementary therapeutic intervention. لكن we don't know whether it works ولا لا.
according to the
يعني لو جربت فيه
according to the NICE بيقولوا we don't advise to give it like the oxygen hyperbaric oxygen. we don't advise this. But the issue is that we cannot nullify this as well. If we according to the NICE guidelines we say no. And don't suggest it to the patient. But what about if a patient came to you and they said, I made this over the hyperbaric oxygen, I gave them my child 40 or 80 or whatever session and he improved too much. It's fine, okay. It's a personal variable. Okay? It's a case we don't know whether he was improved from this or from the other intervention.
الكليشن ثيرابي يعني اصلا كلينيكال توكسيكولوجي كتير بيجي لنا حوار كليشن بقى والسيفتي مارجن. دلوقتي كتير بيقولوا لنا في ممكن نعمل كليشن بالسيفتي ميجرز. ايه رايك؟
انا شخصيا مش شايفه ان فيها سيفتي.
انا بس عشان ابني انا كلينيكال توكسيكولوجي
يعني حياتي بصي واحده في حاجات يعني برضه بالايفيدنس بيس ستادي اللي انا قريتها
انا عارفه ان السايد افكتس بتاعتها
some kids passes they died when they did this so why to expose them to this.
جدا فعلا
طبعا لان بتعمل سيفير ميتابوليك بتعمل هايبوتنشن وفازو فيجل.
طب ايه البدايل لو انا لقيت الميركوري عالي او
let us think يعني in a different way. Environmental pollutants are present everywhere. خلاص we are all exposed to the same pollutants. خلاص إنما for a kid to suffer from autism because of environmental pollutants يعني it's a question. Probably he has another problem that's causing this, which might be mitochondrial dysfunction, for example. So the detoxifying is not working properly. What's sometimes considered safe is giving detoxifying material like things like the glutathione reductase, things like the omega-3s, things like the vitamin C.
يعني اشتغل على ناحية الناتشرال باثويز اكتر يعني.
Natural pathways يعني because you need to think